May we then move on, please, to item 5, which is the review of maternity services and implementing the National Maternity Review. Jane, please would you introduce the paper for us?
Thank you very much, Chair. So what I plan to do is just take the board through where we are with the review, some of the key findings and our proposals for how we intend to implement them. As the board will know, we commissioned Baroness Cumberledge last year to undertake the review of maternity services. That was part of the 5-year forward plan that we had published, and that review was published on the 23rd of February this year. I think one of the key things to identify and highlight is that this review was done on behalf of all of the ALBs, and the implementation of that review is something that we will all be contributing to. So although NHS England will be taking the lead on that, it is absolutely imperative and vital that we will work with and alongside NHS Improvement, Health Education England, Department of Health, etc., in order to deliver it. The findings were really interesting, I think, and one of the key things that they came up with, they actually found that maternity services are now safer than they've ever been, and satisfaction continues to grow, which is really important. And we were also able to show that both stillbirth, neonatal and maternal deaths had improved. However, part of the review was doing a detailed review of quality, which Bill Kirkup led, and that did show some continuing variation and unacceptable variation in care across the country. So one of the key priorities for us will be to improve that level of variation and to help everybody get to be the very best they can. The other issue that I think is important that we note is that our population is changing. The age of mothers, first-time mothers, is increasing. That means that many of those mothers have other long-term conditions, for example, diabetes. We've also got more complex care, and again, that has an impact on how we implement the review findings. One of the areas that I think was particular, or two areas that were particularly interesting, one was that we talk a lot, and we have talked a lot about choice, about the importance of balancing safety and informed choice for women. And a significant number of women do deliver in NHS obstetric units, despite the fact that when you talk to them, they often say they would prefer to give birth in a midwifery-led unit or perhaps at home. And so we don't always balance what patients tell us, women tell us they want, with the reality of that. So the review was very clear about wanting to give women much more choice and enable them to make informed choice, but to do that in a very safe way. And the other point that I found particularly interesting was that many of the healthcare professionals that the review spoke to talked about some issues with team working, maybe some relationship issues between, say, for example, obstetricians, neonatologists and midwives. And that was a really interesting link to what Bill Kirkup found in the Morecambe Bay review. So there was a repetition of some of the issues that came out of that. So again, some of the recommendations and some of the key themes are based on trying to address those. I won't go through the vision and the review details because they're there and the board colleagues will have read them. But just to pick up a couple of key ones. The first one is around personalised care and a very strong emphasis on enabling women to have care that is centred around their own particular views and needs, that they have an ability to make that choice, that we provide them with opportunities to test out a personal maternity care budget, which enables them to look at where they want to have their antenatal, intrapartum, postpartum care. That we look at providing continuity. Again, if you talk to women, one of the things that's most important to them is that they actually know their midwives, that they are able to have a relationship with that midwife that follows them through the time that they are pregnant and into birth and subsequently after birth. And the reality of that is quite difficult to deliver. You know, it's not that straightforward to have somebody available for the whole of a woman's pregnancy. So we're looking to pilot having 4 to 6 midwives that maybe look after a group of people or group of women. And I think that will actually address what some of the issues around patient experience may be, but is important to the women that we serve. There is a very clear overlap with the mental health review. The work on postnatal depression, perinatal mental health was absolutely critical. And so the overlap and the synergy between those two areas, so the two different programmes of work is really important. And I think completely independently, they both came up with the same issues. And I think that just highlights the importance that we're placing on that. Health Education England will be working with us and colleagues around multi-professional working and really trying to do specific training and education with colleagues working together. So we don't have separate education for doctors and midwives, that we actually start to do that together, and we really truly look at breaking down some of the organisational boundaries and working across those boundaries to really wrap services around women. In terms of governance and our implementation, we plan to develop an integrated approach to that with a single implementation board. That will have representation from all of the different ALBs. Each of the ALBs will take a lead on a specific area. So a good example of that will be when we talk about the workforce and education, HEE will clearly take the lead on that. NHS England will clearly take the lead on, for example, choice. And NHS Improvement will take the lead on safety, because as the board knows, the patient safety team have transferred to NHS Improvement as of tomorrow. The paper also sets out the various different work streams that we're going to look at, and I think each of those work streams has got the beginnings of a detailed implementation plan alongside those, and we're also talking at the moment to Public Health England about whether we should have a particular work stream on public health and prevention. We know from experience that the opportunity to improve public health and the prevention agenda is really critical during pregnancy. You are talking to and working with people who are genuinely very keen to have the very best outcome for their babies. You can have an opportunity to influence a whole family, and so there is a really good opportunity for us to highlight that health and wellbeing gap in the prevention agenda as we work and implement this. Our expectation is that we have the first of the implementation programme boards towards the end of April into May, and I'm very happy to come back to the board with more detailed implementation plans, and we will provide that with the oversight and governance that we have for all of our major programmes. So I am quite excited about this. I think it gives us a fantastic opportunity to improve the care for women and their babies, and I think the report gives us a great deal of scope to do that over the next 5 years, and I commend the report to the board, and I would be grateful for any comments. Thank you very much.
Well, thank you, Jane. Let's pick up that invitation to the board for any comments on the report. Moira.
Malcolm, I was just going to ask Jane really about the impact of geography, because it seems to me that we recognise that in lots of places. With a national drive, as it were, there's the opportunity for consistency, but sometimes there's the opposite, that you can't get something that's designed for a particular geography. How is that going to be? Is it local solutions, or is it a national?
No, that's a really helpful question, Maura. The report or the review specifically looked at geography, in particular some of the more geographically isolated areas, and that was partly done as a result of the Morecambe Bay inquiry. The review is also very clear that actually, although there is a national framework and national guidelines, that the only way that you're going to be able to do this is through local adaptation. And so the vast majority of this can be done locally. We just might need to shift and alter slightly how it's done, and one of the key issues will be the relationships with wider networks. So one of the recommendations looks at creating a wider network of maternity both services, both from a commissioner and a provider point of view, and actually the best way of doing that is in geographical locations. And so we would have the opportunity to share and use different types of technology in order to support women in different parts of the country. So national oversight, national recommendations, but local adaptation, local review.
I guess one of the areas, as a sort of, if you like, somebody who's observed this for the last couple of years, strikes me that making progress on mental health has proved to be one of the hardest things that we've been faced with in terms of demonstrably making change for the better. One of the absolute critical recommendations here is an improvement in the service, perinatal, postnatal health, mental health. And I guess, therefore, I'd be interested in knowing, what are we going to do differently? And is there actually the skill and capacity and capability locally to deliver what's required? And if not, what are we going to do?
I'll start, and Bruce may want to pick up from the mental health review, because obviously there's an overlap between the two. So we have got some good examples of that. So we have got examples of midwives who have been specifically trained in perinatal mental health, who have been doing some really, really positive work. And in fact, we were only discussing that this week with a consultant who's been leading a lot of that. In addition, when we created the additional health visitor workforce that we worked on over the last few years and completed last year, one of the very key high impact actions that those health visitors were trained to do was to look at perinatal mental health. So we increased the number of health visitors across England by a significant amount to at the time over 4,000, and I think that's also helping. Part of the recommendations also talk about having a longer follow-up care for women postnatally, and to enable, for particularly higher risk women, for them to have access to both midwifery and then subsequently health visitors support for maybe 6 weeks, as opposed to the current for midwives, few days. And again, so that will provide some consistency and some continuity. I don't know whether Bruce wants to add anything more for the mental health review that we could, but the two, they will lead that part of the implementation.
I don't think I have a huge amount to add, other than to say that it's also a priority in the mental health review, and we have a team working on that. I think there's a bigger issue, though, David, and that is how we integrate our mental health endeavour into all of the major reviews that we're doing. So it's important in all long-term conditions. It's important in our cancer review, and it's obviously important in the maternity review. And we're cognizant of that and trying to bring a coherence of approach across all of them.
Can I just go to John?
Jane, as the proud grandfather of 2 home water births, which I was very impressed by, although no one mentioned how hard it is to empty the damn thing afterwards. I've been thinking very much about the safety issue and about diversification and personal choice. And one of the questions that I'd like to expand on is this question of technology and information sharing. Because obviously if we're moving women away from obstetric units, then sharing data and record sharing is ever more critical. So we've said that we're committed to the development of a digital portal. That doesn't give us a good time scale. Have you got a feel for how long it will be with the work with the National Information Board before we've got a digital portal?
I can't tell you that now, but we have got a plan to do that, and it is part of the work that the NIBID are looking at. So I don't know, Karen, you've got the detail. I haven't got the detail to the top of my head, but I can certainly come back and let you have that. What we do know, though, is that the work we've done so far and some of the early adopters that we will look at will actually start to really test that out and get that up and running and show the positive impact that it can have.
Just to reinforce that, we don't have a timetable for that yet, but that's part of the plan that we're pulling together now as we allocate the National Information Board funding associated with the various domains, and this is clearly a significant priority that we will be looking to take forward. So with Jane's help, obviously, and under that.
And one of the issues around about choice is enabling women to have a really informed choice, so that they understand that maybe some of the risks involved, but also making sure that there are very good sort of agreed pathways so that people can flip from potentially a home birth or a midwifery-led unit birth into something that actually requires maybe more intensive support or an obstetric unit, and that is a very clearly set out agreed pathway for women and their carers, so they know what the issues are and they know how that can happen, and that's really important. choice is vital, but safety is absolutely critical, and we need to be able to marry the two together, and that's one of our key priorities.
Just welcome the report's really good stuff, and as a former president of the Health Visitors Association, I welcome the increase in health visiting numbers. I was just curious about a couple of things. First of all, not all women are the same, and I'm particularly keen on what you might have to say about the most vulnerable women, the women least likely to make choices. I'm curious about where the energy in the report is around that. And the second is, I note that the Mental Health Task Force are taking charge or taking some leadership around the mental health issue. What I'm interested in is who's holding the ring locally. While I note your point about health visitors being trained, it's how the mental health system takes up that role, and have we got thoughts about who might be doing that locally? Because I think in the past what's happened is women have fallen between two stools. So I'm curious about that. How have we got thoughts about who's picking it up locally, who's in charge effectively?
I think the point we've made is that, or one of the recommendations, that there should be these networks. The other issue we've done is we've just issued invitations for those that want to pilot the choice work, and we are going to have early adopters that we're going to start to look at for later in the year. So I think the proposal will be that through those early adopters we actually are able to demonstrate and test what different local models might look like in order to address that. Part of the review certainly did concentrate on looking at access to and choice options to everybody, and not just a certain cohort. And it's back to this issue about looking at the population, looking at the almost segmenting the population that we've got, and actually making sure that the recommendations are applicable to everybody and not just a certain group. The other important area, I think, is highlighting that by having Bill Kirkup as part of the review team and leading the quality part of the review team, and having key colleagues that were involved in the Morecambe Bay inquiry and the report, that's actually, so the links between the two, I won't use the word synergy again, but the links between the two were there for a very specific reason, to try and make sure that we did ensure that this report and this review did look at the outcomes of that too.
Good. Well, thank you very much, Jane. I think the board notes the recommendations and will give full endorsement to the high-level approach for implementation that you're proposing. Could I just suggest one thing? The governance arrangements will have an implementation board reporting to the 5-year forward view programme board. I wouldn't wish this board to lose sight of what's going on, so perhaps in a year's time, if we could have a brief update and an understanding of how the implementation has worked through, we'd be grateful for that.
Absolutely, I would consider that to be one of my priorities, so yes.